Good afternoon, ladies and gentlemen, dear colleagues. I welcome you to the second webinar dedicated to laparoscopic colorectal surgery. My name is Andreas Chamier from Linz, Austria, and I welcome the co-faculty. We are a team leading you to 11 webinars. You can see on the screen Colin Sietzes from the Netherlands, dedicated expert in colorectal surgery, and also Walter Brunner from St. Gallen, Switzerland, also well-known expert in laparoscopic colorectal. And as our guest faculty today, Professor Khaled Madouli Mahaba, who will join and give also a lecture. He's a well-known expert and also president of the Egyptian Board of Colon Rectal Surgery and editor of many established journals, and we're part of the faculty this afternoon. So I hope you enjoyed the last webinar, and we will start with the second one right now. As a reminder, I show you the whole schedule of 11 webinars. On that time, I would like to say my deepest thank you to Medtronic International, who makes it possible to share our knowledge with you in this difficult time of the COVID-19 situation. We had a first webinar, module 1, last week on the basics, and you can see the 11 modules following number 2 right now. And they are structured that each is following the next one, giving you best possible support for the best outcome on your patients on laparoscopic colorectal surgery. The today's faculty already showed. I just will give in a few minutes Walter Brunner the word for patient selection. Then Colin Sietzes will talk on the description of the full procedure, left colon in malign disease, followed by Walter Brunner on benign disease. And I will give you some tricks and tips of my experience. And Professor Madouli will give the local perspective of Egypt and regional specific aspects. And then we should have time for 10 to 15 minutes for discussion. Please send us your questions on the chat or in the E&O questions. Please don't expect a written answer. We will discuss, we will collect the questions. We cannot answer all the questions, and we have it as a live podium discussion with you at the end of the webinar. Now, please, like in an airplane where you have the safety guidelines, take 2 minutes, read the rules of the webinar. Okay. Thank you for your cooperation. You can leave the webinar anytime you want to, and you also can give your friends, if you like it, the tip that the next webinar will be soon. So that's just for the beginning, all of me. Thank you for being part of us this afternoon. And now I think we will start with Walter Brunner on the patient selection and indication for left-sided. Walter, please, your turn.
Okay, welcome also from my side. I'm Walter Brunner, as already mentioned, from St. Gallen, Switzerland, and it's a pleasure to have you all here. I hope you enjoyed the last time and you will use the chat. So I will talk a little bit about the patient selection, the indications, and also a little bit of preparation, what we can do. So of course, the patient selection for laparoscopic surgery started around 1991. You see, this was the first publication when Jacobs made around 20 patients, right and left side. And it's extreme interesting. He also put them on fluids from the first day. He discharged them within 96 hours. So it was a little bit of fast track with a regular diet, which we come back later on, of course. And although he said laparoscopic assisted colonic surgery may still be considered a procedure in evolution, we feel that in time it has the potential to be as popular as laparoscopic cholecystectomy. And nowadays we know that maybe not 90% is done in a laparoscopic way, but depending on the country, in some hospitals, it's already as high as that. So laparoscopic assisted sigmoid resection was also done by Fowler, also published in September 1991. This was the start, and now you know that we have a lot of options to do minimal invasive colorectal procedures, and most important is to choose the right patient, but also the right team. Conor Delaney said, would you prefer to have an operation which requires a longer scar with more infections, is more painful, it bleeds more, requires a longer hospital stay and recovery for the same oncological result? And this, I think, is really important. We have, if we do on malignant disease, the same oncological result as we do an open procedure. And of course, maybe the strategy is a little bit different if we do it in a benign disease. Colorectal is always selection of patient important, and it's always an advanced laparoscopy. So the selection of patient is important. And maybe you will not start with these ones. It's also the placement of the patient that you have a good option to do your operation. It's the placement of the surgeon and his assistant will give you maybe 50% of the possible success. If you place your trokars perfect, maybe this gives you up to 70% of the possible success. You cannot do an operation like this for 20 minutes or 30 minutes, if you look like that, or for 4 hours, it's not possible. And of course, you can put as much trokars as you want, but it does not make sense. So better you have a good strategy where you place your trokars. And the last thing, of course, is your operative strategy. We are talking about the next 1.5 hours, which will be able to give you up to 100% of the possible success, which does not mean it's exclusive also that you convert to open surgery, maybe if necessary. So the strategy should be easy. I always call it, it's the 5R. You should have the right patient on the right side, in the right time, with the right team, and then the right technique. It would be perfect. And if you miss one of these ones, maybe it's a little bit too early, and it could happen that you think you are already done, but you are not done up to now. And then somebody else takes the victory for you. At least the patient should have a victory. So the patient selection, it's depending on expertise, of course. So you start maybe with easy procedures and you go to complex surgery. You follow a training protocol in the beginning. We do mainly sigmoid resections first in steps and then up going to a full procedure, including flexion mobilization. We don't start with oncological cases. Even sometimes they are much more easy. If it's a small tumor, then it's a huge inflamed case. So, and then we step up to more difficult cases. And standardization definitively is crucial. I will show you my personal golden rules in the next webinar in 2 weeks. And then in the end, maybe it turns around which you should not operate in a laparoscopic way. But in the beginning, you will start definitively with some easy procedures. So I will go for those who will not be operated laparoscopic because there are some contraindications, of course, and this is all the contraindications you have for laparoscopy if they are unstable, if they have cardiovascular problems which you cannot handle during the operation, if there is a pneumoperitoneum, maybe you have pulmonary reasons why you're not able to do laparoscopy. Well, this seems to be clear. But then there is also, due to previous operations, maybe dense adhesions, which do not allow laparoscopy, or you have a huge tumor where you need a large incision anyway. Maybe also parts of the T4 tumors are not able, but you will see we'll have a webinar on T4 tumors where you are able to do a T4. Even some guidelines recommend you should not do, but there are some options you could do that. And at last, if you have a limited space or a limited overview, and this is especially true if you have an ileus, you have some dilatation, or even you have perforation with a lot of stool intra-abdominal, then maybe laparoscopy is not the best way to go. And you can imagine, for example, if you look on these slides, this will be difficult if you have that huge dilatation to have enough space and maybe be able to resect that. On the other side, there's of course some topics you should consider if you go for operation. And the one is of course obesity. The other, which is always in discussion, is age. Then if it's elective or emergency surgery, if it's a tumor, malignant, or it's benign disease, and then what team is available. It's a difference if you do it in the night or by day, and also if you have a good standardized approach and also a good conversion strategy. So conversion, if you do it on strategic and not on reactive, is not, of course, not worse. It's a good thing to know I can convert, and you should convert in between the first 30 to 60 minutes to be able to not harm the patient. So let's talk about obesity. As we know, mainly it's BMI related, and they have a higher risk perioperative, especially patients with a BMI higher than 35 or 40, which means class 2 and 3 obesity. The approach is more difficult. Maybe you need a special table, you need longer trokars and instruments. The overview is worse because bowel and fatty tissue is always in your field. The vessels are hidden in fat, and even very small vessels, other people, patients do not even have a problem with that. They are enlarged and very vulnerable. So if you touch the fatty tissue, maybe it breaks and you have a lot of bleeding inside, and the overview is worsening again. The bowel is often hidden in between the fat and often very narrow, so that's also not easy to handle. And the conversion should be early. And then if you convert in an obese patient, that's also not easy, and you have an extensive abdominal wall wound. So these patients are not easy, not in laparoscopy, not in robotic surgery, and not in open surgery. You have to be aware of that. So that's, of course, for the experts. Maybe it's even better to take a look on the waist-hip ratio, because it was shown that only the BMI does not give you if a case goes difficult or not, but it's mainly the waist-hip ratio. And if we look on the waist circumference, that's a little bit different in male and female. You see that this is normal, low risk, and high risk. And if the ratio is more than 1 in male and more than 0.85, then you see this is abdominal obesity, and this will get problems for you during the operation. You can measure that. That's quite easy. There is a publication about that of the waist circumferential study group, which was published in Annals of Surgery. And sometimes it really makes sense to figure out where you could run in problems. And it's interesting, if the waist-hip ratio is not good, you have more intraoperative adverse events, the conversion is higher, you have postoperative medical complications and need for reoperation much higher. And also only the waist circumference gives you more postoperative surgical complications compared to the BMI, which only gives more abdominal wall complications, but not the intraoperative one, because it really depends where is the fatty tissue. If you have a look on the CT, of course, you can be prepared. You see where is the fatty tissue. For example, you see this is more outside, inside there is not too much. But if you look on the other picture here, you see there is fatty tissue outside. There is everything is black. So if you have a lot of black inside and not only outside, you need on the one hand longer trokars, but you also will run into fatty tissue when you go inside. So this will maybe cause a problem for you. And you see this patient even had a drainage because of an abscess. So you know, you look good on the CT and you see what you will expect. Second thing I will talk about is the patient selection of age, and because some people say if people are older, you should not operate on them laparoscopic way. Well, that's not true. There's a nice systematic review which showed that in most of the publications, age even over 85 had similar advantages over open surgery to those demonstrated in patients of younger ages. So it's not the topic that people are older. The thing is, during the operation, maybe pulmoperitoneum, you have to be very careful for them, but post-operative, they have really an advantage of the minimal invasive approach. The next thing is elective versus emergency. Of course, we expect that in elective surgery, we can be higher with laparoscopy. And they're, depending on the hospital, there are some who are not doing laparoscopic colorectal procedures at all, and others are doing in an elective setting over 90%. In the emergency, there's rarely more than 10% done in laparoscopic way. And if you look in mid-Europe, overall it's around 35 to 50%. It's increasing and really depending on the hospital. But overall, it's around 50% for sigmoid resections and 35% for all procedures done on the colorectal way. There's a nice diverticulitis study which was done in Switzerland. Unfortunately, it's not published, but it showed very good what happens to people which were coming in a hospital with diverticulitis. And you see there were 1,000 people in 75 Swiss hospitals. Elective were 214 cases. And the only thing I want to point out is in laparoscopy, they had 96% of elective surgery. The conversion rate was around 10%. And in the emergency case, and this was really unexpected, those who had to be operated, they even started 43% laparoscopic. And the conversion rate, of course, was 1 out of 3, which makes sense to have a look in, because if you can do it laparoscopic, why not? If not, you can convert to open. And you should decide that rather, as I told you, rather quick. Another thing are the indications. There are some indications from malignant to benign, and we will run through that. And of course, that has different needs and different strategies, because we also want to have some different result in the malignant disease and in the benign disease. Sometimes you are not sure if it's malignant or not. Imagine you have a perforation on a bowel wall thickened in the sigmoid, and you know that there was never a colonoscopy, but you see some diverticles. So you're not sure if this is a diverticular disease or this is a malignant disease, and I will show you what option you could do. This is the lymphatic anatomy of the colon, and it's clear, as I showed you this picture last week. You remember this is between left and right side. It's the mesenteric root. And what we need is, for the oncological resection on the left side, we need all those lymph nodes in. And this is important, of course, for the malignancy. And if we have a goal for malignant resection, then it's a correct interfascial dissection with a complete intact embryological package with intact lymphatic structures, and also nerve sparing technique. So we want to have very good function afterwards. There are some scores who show the pathologist can tell us if we did a good Quirke score or Mercury score, and also there are functional scores to figure out if we did a nice operation. This is important, of course, for the malignant. The lymph node harbors, central ligation of the artery, the vein, depending what length you need, if you have to take it on its origin, or you can take it lower down. There are some techniques we know already from no touch, etc. This will be done by Colin probably, and there are some indications and contraindications. Of course, you should have your experience if you do laparoscopic colorectal cancer surgery. And then there is no locally advanced. You see that no indication for acute small bowel obstruction, perforation. This is what I told you, which is for all. If you have a lot of bowel obstructed, it could be difficult. Of course, you have to explore the whole abdominal part. And maybe if the lesion is small, you should consider the marking of the small lesion before. For benign disease, it looks a little bit different, because maybe there are other goals, and this is mainly less harm and better function what we want to have. And there are good papers on the preservation of the inferior mesenteric artery in colorectal resection, which gives you better blood supply and lower leakage rate. There are some of the papers and others, and they are around 5 to 10 years old. They also show you that the denervation you do, if you cut central, all those parts of the colon, even you do not resect all, will be denerved. So maybe you also get some better function if you only cut those vessels which are really close to the bowel, you resect, and this part is not defunctioned, and that gives a better function postoperative. As we know, 35 of all the sigmoid resections have a Lars syndrome, which seems rather high, and people always thought this is only in rectal cancer resections. They will have a low anterior resection syndrome, but this is also true for sigmoid resection. So if the strategy is unclear, one case I showed you before, if you have a perforation and the bowel wall thickened, you don't have an idea that there is a colonoscopy before. So you can either go on the safe way, you go for oncological resection with a central dissection of the artery and the vein, but then maybe you did over treatment if you end up with a diverticulitis. And what you can do is you can add tubulary and preserving the inferior mesenteric artery, tubulary resection, and on table you open the specimen and have a look if there is a tumor. If not, it's good. If there is a tumor, you can resect the lymphatic. You can do the lymphadenectomy in a second way, because if a perforation was at the site of the tumor, it does not matter if you cut through the meso anyway. That does not harm additionally. So another thing is where to transect up oral on the left side. This is just to complete the left side. What we know is that there is a high pressure zone, and you should be aware that between the sigmoid and the rectum there, if you put there some electrode, you will see there's a kind of a rectosigmoid sphincter. And if you resect that, you get more option for a recurrence of diverticulitis and leakage if you let that in, or if you stay in the upper rectum and resect that, recurrence of diverticulitis and leakage is going down. So this is especially for benign, but of course, if you have a sigmoid cancer, you should also end up in the upper rectum and not stay within the sigmoid because of the high pressure zone. You should resect anyway. So the last thing I have to talk about is the preparation. Of course, we know that we have some influence before we go in an operation, if it's not emergency, meaning diabetes or organ function like liver or kidney, or also pulmonary function. You could do something before, and also the nutrition status, also the fitness of the patient. If you have time enough that they get more fit, it makes sense. And also you can maybe influence the medication. We know that patients under steroids, especially if they take an equivalent of more than 20 milligrams of prednisone, it's better to lower, if possible, this medication, or consider to do a stoma and not an anastomosis. There are other things you have no influence on, for example, the age, the tumor localization, previous therapies and operations, and also if it's an acute situation, we cannot deal with that, but what we can deal with those things, and there's some nice programs like fast track surgery and enhanced recovery after surgery, but that's not only after surgery. If you have a look, there are a lot of things which contribute to postoperative morbidity, and there is a big part which can be done pre-operative, that you try to optimize the patient, but also not in knowledge, but for his physical situation. And you can look at how many people are, of course, involved there. It's not only the anesthesiologists and the surgeons, there are some others you will need, and also the nursing care is very important, and I hope a lot of people are going on that way already. That's also good for open surgery. It's not only for laparoscopy, but they really profit, and there are some publications and guidelines, and you can go on the web page of the ARES Society and you will find everything, also events you can share, but also their guidelines, what should be done, and their recommendations. I will not go in further detail for that, but only two things to discuss, because it's now very popular. Can we reduce the surgical site infection with mechanical bowel preparation and oral antibiotics? And there are some main questions. We did bowel preparation years before, then it was stopped, and only in the rectal cancer we kept it, but the others did not get. Then they started oral antibiotics, and mechanical bowel prep came back again. Well, for the moment, we can say it's not quite clear. If something there, it should be perfect. But you see, this is one big meta-analysis showing there was no significant difference in anastomotic leak rate between the four approaches, but the lowest rate of surgical site infections. And then the question is, do you know the surgical site infection in your hospital at all? And maybe you reduce it by all the other things which are in the ARES program and by laparoscopy. And if you have then 2 to 5%, so the question is, how many patients do you need? And you have to treat them with oral antibiotics and mechanical bowel prep to reduce that for a few patients. So it's a little bit open. Even there are some who say it lasts very long. This is one publication that it needs 10 to 14 years until people are there. But then obvious, I'm sure we will have more knowledge what really should be done with the bowel preparation and the oral antibiotics. Thank you.
Thank you very much, Walter, for this excellent introduction on indication, patient selection, and preparation. We will discuss at the end, after all the lectures, and again, a hint from my point, please feel free during the lectures, all the audience, to send us your questions on the topics, on the lectures, using the chat or the F&A just below on the screen. Before we now move on to Colin's presentation, we would like to ask you, the audience at home, a few questions about the situation in your clinic, in your country. Maite, if you could please start the questionnaire. Okay, question number 1. What is the caseload of colorectal resections in your clinic per year, despite Corona, so just a regular year? Please. Okay, we will show you the results later on. We move to the second question. Oh, okay, so let us see. It's almost equal, lower than 30, between 30 and 60 the most, 60, 100, 24%, and more than 100, 22, 1/5 of all the audience. And we are about 500 participants today. Okay, let's move to the next question. Maite? Please, yes. How many surgeons in your clinic perform colorectal surgery? Up to 2, up to 4, up to 6, or more than 6? Okay. So most clinics have 2 surgeons, 1 to 2 performing colorectal surgery, 1/4, 3 to 4, and it's almost the same for more than 6, and 20%, 90%, 5 to 6. Okay, very equal, all the questions today. Please, Maite, give us the next question. How high is the percentage of elective laparoscopic colorectal resections in your clinic? So out of all elective surgery, what is the percentage of the laparoscopic ones in elective surgery? Benign and malign disease, of course. And this is anonymous, so you can be very honest and give your real numbers, because nobody knows from the results what is happening in your personal clinic. Okay, let's check it out. Okay, so most of them less than 10 or up to 10% laparoscopically, and 31%, 1/3 is more than 50, and the rest is similar between 11 to 25 and up to 50. Good. Okay, I think we have a final question. The last question. Do you have written standards, SOP, standard operating procedures for laparoscopic colorectal resections? Is there a system written down? Okay. Okay, half of the clinics have no standard, 10%, 11% has a standard, 1/3 not written but educated step by step, and 6% do not know. Interesting result. Okay, I think this was the last question. And thank you for voting. Thank you for being with us. And now we move on for the next presentation. I'm going to ask Colin Sietzes from the Netherlands, giving the description of the full procedure on the left colon on malign disease. Colin, please.
Please unmute yourself, Colin.
Yeah, I will. So, I'm unmuted. Okay, thank you, Andreas, for the detail for the introduction. I will now continue with the detailed discussion of both the left colectomy and the sigmoid resection. Personally, I will do the malignant aspects of the laparoscopic left colectomy, and Walter will then continue with the benign aspects of the sigmoid resection, but he will also show some of the steps of the malignant sigmoid resection. Why is it working? Yeah. So, what are the key points for good laparoscopic left colectomy? Well, first of all, you need a complete mobilization of the splenic flexure. And since this is also a subject in the module 4, I will now only focus on the basic steps. And in module 4, we will go into more detail and also show you the pitfalls of the flexure mobilization and the different ways how you can do it. Second key point in left colectomy is making sure that the vascularization is not compromised after you're finished with doing the flexure. Otherwise, you will have a problem, of course, when you try to re-anastomose the bowel at the end of the procedure. And the third point is doing an optimal lymph node dissection, of course, with an optimal vascularization in the back of your mind. So how are you able to do this? Of course, you need a thorough understanding of the anatomy, about ligaments and attachments between the colon and the other organs, but also about the vascularization and anatomical variations which exist. You need to understand the rationale behind the extent of the lymphadenectomy. Two recently published studies of Spanish groups by an author called Garcia Carnero are essential reading by what I consider. They give a beautiful description of the anatomy of the splenic flexure, and some of the figures in these papers I will use in this presentation. So let's start with the mobilization of the left colon. The anatomy at first hand doesn't look that difficult, but the embryological development of the abdominal cavity resulted in the fixation of the transverse and descending colon to neighboring structures, which makes the complete mobilization quite a challenge. 4 attachments have to be dissected to completely mobilize the splenic flexure. The first attachment is the attachment between the parietal peritoneum and the visceral peritoneum. which is called the phrenicocholical ligament. Second attachment which you have to cut is the attachment between the omentum and the transverse colon, which of course is called the gastrocolic ligament. And the other attachment which has to be dissected is the splenicocholical ligament, the attachment between the spleen and the colon, and the attachment between the transverse colon and the pancreas. The attachments can be dissected in a varying order, and traditionally these attachments were mobilized from lateral to medial. So they started with the phrenicocholical ligaments and then worked medial. Personally, I prefer to do the dissection from medial to lateral, so I start with the adhesions between the mesentery of the transverse colon and the pancreas and the work lateral. If you do this dissection from medial to lateral, of course you need a thorough understanding of the anatomy, because this is of the vascularization, because this is the most variable aspect of the colonic of the colon. And sometimes it's really complex, which you see on the right side, but sometimes it's really easy. And if it's complex, there's little room for error. There are three vascular structures which you should consider. The first one is always present. It's called the marginal arterial, or the artery of Drummond. It joins the left branch of the middle colic artery with the terminal segment of the left colic artery. This is the nearest arcade to the colon. More centrally located is Rioland's arch. It connects between the left branch of the middle colic artery with the left colic artery. And more centrally is the artery of Moscovitz, and this is found just above the ventral edge of the pancreas. And it connects the middle colic artery with the left colic artery. Here's some anatomical dissections of this. And both the Rioland's arch and the artery of Moscovitz are highly variable and not always present. As mentioned before, for a left colectomy, an adequate lymphadenectomy is also needed. And there's a lot of discussion and variation in what is considered an adequate lymphadenectomy. More and more surgeons have adapted the principle for complete mesocolic excision. And Walter also described it in his last presentation in Module 1. And the concept of CME is similar to the philosophy of a total mesorectal excision. An embryological fascia, the mesocolic fascia, envelopes the colonic mesentery. And instead of dissecting through the mesentery, the avascular plane between the mesenteric plane and the retroperitoneal plane is dissected. And if you do the dissection along this plane, you ensure that you have a complete removal of all the lymph nodes and you have a complete specimen. Sorry, I go back one. The second component of CME is the central vascular tie to completely remove all the lymph nodes in the discentral direction. And the third component is the resection of an adequate length of bowel to again make sure that the number of lymph nodes is sufficient. So what, according to the CME principle, is considered adequate lymphadenectomy? Of course, this depends on the location of the tumor. For tumors located around the spleen, at least the left branch of the middle colic artery should be included and the origin of the left colic artery. For more distal tumors, the sigmoidal branches should be included as well. The question is, how central should be located? In this picture, a low tie is shown. The inferior mesenteric artery is preserved and the left colic artery is dissected. But you can also, of course, decide to dissect the inferior mesenteric artery at its origin. There are both advocates of the high tie and the low tie. In the high tie, the EMI is located as high as possible, and in the low tie, the EMI is preserved and the artery is located at the branch of the left colic artery. Advantages of a high thigh is that you have more length and a more optimal lymph node clearance, but advocates of the low thigh say that they have a better blood preservation and a decreased risk of plexus damage. And to my knowledge, there is no studies showing advantage of one or the other, but I personally prefer the high thigh because I always want to have enough length for the re-anastomosis. So that's essential, I think, to do. So the rest of my presentation, I will take you to the different steps of a left colectomy. And there are, in my opinion, 11 steps varying from patient positioning to re-anastomosis at the end. And I will take you through them step by step. First of all, the preparation of the patients. Like Walt already said, we don't have any bowel preparation and patients get prophylactic antibiotics, and we treat these patients according to ERA's protocol. Patient positioning varies a little bit from surgeon to surgeon. Personally, I prefer just right tilt, but some patients also want the patients in Lloyd Davis position where they can stand between the legs. For me, that's not always possible or not necessary. The trocar placement, one at the umbilicus, at 10 millimeter, we do an open introduction and then 3 extra trocars at 12 millimeter in the right lower quadrant and 2 5 millimeters in the right upper and the left halfway. So the first step we do is localizing key anatomic structures. So you first have to have your operative field cleared so you can see the different structures and you can start your procedure. So you need to tilt the patient to the right side, sometimes quite extreme, so you can put the small bowel in the right side of the abdomen and you can see the inferior mesenteric vein. Then the next step is that you flip over the omentum over the transverse colon, and then you can see the lower border of the pancreas and again the inferior mesenteric vein. So if you've done that, you are clear to start with the dissection. The first part of the dissection is that you lift up the inferior mesenteric vein and go quite close behind and develop the plane between Gerota's fascia and the mesentery. Here there were some adhesions, so you can see that the Gerota's fascia is opened up a little bit, but mostly you can just keep it closed completely and you work your way lateral as far away as possible. So you continue as far as possible, and I personally prefer to leave the inferior mesenteric vein intact so I can lift it up and go as low as possible. The next step is that I cut the inferior mesenteric vein. Again, you see clearly the anatomy here with the lower border of the pancreas, and I use clips to take the vein also for marking it so I know later where the highest lymph node is. So we cut it with the ligature, and then we go to the next step. And the next step is a really important one because we make an extra opening in the mesentery of the transverse colon. So we get into the lesser sac. And then we have 2 windows, one over Gerota's fascia and one over the lesser sac. And then we can connect these 2 and work lateral. And again, you do the dissection as lateral as possible. And make sure that you don't damage the pancreas, because if it leaks pancreatic fluid, you have a problem afterwards. But you can clearly see it, and you can do really precise dissection laterally. Again, continue as far lateral as possible. This makes the dissection on the lateral side easier at the end. So if you've done the dissection over the pancreas, you make an opening to the lesser sac over the transverse colon. And in this case, the tumor was still in the transverse colon, so we decide to dissect or resect the omentum with the tumor. As you can see here on the top bottom, there's still some omentum left at the tumor. And afterwards, we do the dissection to the lateral side with the ligature. And then if this is completely freed, we go to the lateral side and you cut the last adhesions. So you cut the adhesion between the peritoneal and the visceral peritoneum. And as long as you've gone far enough from the medial side, you only have to cut the last adhesions on the lateral side. This is the last adhesions from the phrenicocollateral ligament. See the spleen behind there. And now it's completely freed. See the tumor with the marking and the omentum. Then you cut the mesentery and the colon. And then you go back to the transverse colon and you lift up your specimen and you look where the middle colic artery is. And in this case, I decided to preserve it. You work upwards along the middle colic artery. Until you see the left branch of the middle colic artery, and then I use clips to dissect this one. Here you see the clips below, and then we dissect the bowel with the stapler. And then we position the specimen in the lower abdomen and we make the re-anastomosis. We always look with ICG to see that if there is a good vascularization, and then we make a stapled anastomosis. And the small defect which is left, we close with the V-lock. Of course, if the dissection is more distally, you can also use a circular stapler, and Walter gonna show you that in his presentation. So this was my presentation. I give the word back to Andreas.
So thank you, Colin, for the nice video, for the excellent presentation. It was really nice to see the intracorporeal anastomosis. We move on, and Walter, it's your turn now, please, about the full description of the sigmoid resection in benign disease, and as we heard from Colin, on the also malign disease. There's one question of the audience: if there are interesting parts of the video, maybe the presenter can use the cursor to show it better. Walter, please.
Wait a little bit. So do you hear me now? Okay.
Okay, Walter, we can hear you, but we cannot see you. Maybe you start. Yes, now it's perfect.
So now it's working. Okay, perfect. So as we saw, this was the malignant part, and I will show you how you could do it with the benign disease. Actually, that's different because, as I told you, we want to make less harm, and maybe we also have a better function. And I will show you how to simplify these procedures because some do not really know how this works. So I will show you some tips and tricks and also talk about specimen retrieval and anastomosis and stapler and the check of the anastomosis. So let's have a look on those video. So you see that there is, I hope it works, yeah. We have a look on the right side, on the right urometry. You see here adhesions, you see a very chronic inflamed sigmoid with a lot of diverticular. And in this case, I start lateral. There was one question, should we start medial or lateral? And in the benign disease, I always come from lateral. Even this is more important in the malignant, that you have a real no-touch technique. So you should not touch the tumor at all. And this is why we go for vessels first, and they are medial. So in the malignant disease, we go for the medial approach. And for the benign, I would recommend to come from the lateral part, to just open the peritoneal fold here and be able to come to the midline again and flip the sigmoid straight up. You see, we are looking here for the line again, that's Toll's fascia. It's the same as we had in the malignant case we saw last week, and also Colin showed. And you just release it maybe up to the flexure. So that's the first part you do. And then we proceed. If we are able to see the ureter from the lateral side, that would be perfect, especially if the sigmoid inflammation was going anterior side, which is in many cases there, that it's going to the bladder or to the peritoneum of the anterior side, then you should be able to go easy on the lateral side. This is one of the places where you perfect find it on the descending colon, and then you go down, because on this descending colon, if there's no inflammation, it's easy to find. And also here, we just open the peritoneum, we go down to the peritoneal fold just to open it a little bit, and then we have a look. And you see here the ureter is moving already, and always if you do one thing, you should be focused on that, but you have in your mind there are some important structures. Now I put a swab behind the sigmoid and I lift it up, because what I want to do now is I want to preserve the inferior mesenteric artery. You see, this is iliac vessels, there is the ureter. I have a look for the right ureter. This would be ileocecal region. This is the promontory, and normally I would open up here. This is the line of the rectal superior artery, and I start high up where I'm sure these are just the sigmoid arteries here, and the rectal artery is going down. So I preserve the inferior mesenteric artery going to the rectal superior artery. And then you just open the peritoneum. And what I want to have is, I want to see my swab on the back side. You see that the preparation is just down through it, even if it's inflamed, and sometimes it gets laterally, and put my swab on the back side, then it's rather undangerous that we are able to go there. So then the next thing is, it's important to just run down quite close to the colon, because I don't want to cut the superior rectal artery when I go down, so that would be senseless. I want to stay rather close to the colon. You see that? You come down here, the colon, very close, and then you make your dissection just on the height of the promontory, so you leave another at least 8 to 10 centimeters of the rectum. You also saw that there was enough of the blood supply. You saw that on the video. Maybe I jump back for 1 second, that you see that the color here, you see that brilliant. This is without blood supply, and here even nearly the whole sigmoid has blood supply from above. Even I cut those vessels there. So, and then you see there are a lot of divertics, and I want to make my transection above the inflammatory part. I will not cure him. This line I showed you now, I have to go back a little bit. This line is if you want to gain the length. So you see here the inferior mesenteric vein. So my aorta is here. The artery is coming from here and is just below my transection. I just preserve the artery. But what I can do if I want to have length is I want to go along the vein. And I can do the same as Colin showed. I can cut it very central. I can make the whole flexure mobilization and have the same length of the descending colon. So if people say we do not resect the same and we have more tension, well, then they did not realize what the idea was of preserving the artery. So this is the idea of preserving the artery, but you can cut the vein if you run up here and have the same easy going down to the rectum and no tension. You see, here's the vein. I even can preserve the vein and just cut the left colic veins coming in here. So maybe I preserve the central one. You see here is Toll's fascia, and I can go up and do the same as Colin did before. You see, this is perfect. The white line of Toll, I can go down there. And then I define always the resection point intra-abdominal. I'm looking now for the arcade and I cut, so I preserved. You see, this is important that you're not going too close. I come from below back to the point where it's perfect. You see, there's no blood supply. If I put it out, you can put it out, of course. It's important to do it via a protection foil. You measure it immediate because all the people want to know how much did you resect, so I measure it immediate. I think most of you will be familiar with the circular stapler. You make a very nice purse string. If you have a diverticle there, you don't want to have it on the edge of your stapler. That would not be nice. So you just suture it towards the midline. There should not be too much tissue. Then you come from below. If possible, don't go in the middle. Everybody is advised to just go here in the middle. But if you just go in the middle, you have two weak places. So I try to staple away the anterior posterior part. So I come rather close here. And you see now the anterior edge is gone because on the posterior I will not be able to do that. I will not rupture the stapler line here. That would not be perfect. You put it together, you look for rotation, and if it's tension free, and be aware that if that was a little bit too fast, sorry, I go back for that. I have here my stapler, I run through here. And then what you want to do is if you fix it together, the lower one does not work at all. And be aware that your bowel maybe went below your neo-sigmoid, and then you have already an inner hernia. So you have to be aware to bring it out and maybe to close even the mesenteric here. So that would be perfect. And then you do the check for the anastomosis. I think everybody knows, have a look inside. Don't only do air in, but have a look inside, and then be aware that the bowel loop is crossing over your mesosigma. If this is too close and you have the jejunum, the Treitz flexure complete free, it's too difficult. It's too easy that it goes back and you have an inner hernia. In the end, you will put your omentum through. Normally, we don't need any drainage on the sigmoid resection. That was the first one. I just show you what happens if this is a more difficult case. It's the same standard technique we do. You see the swab behind. And this is just to show you if it's more difficult, and it looks really the same. The artery is below here. I will preserve the artery. I can go up to the vein. Then I go down to the bowel and run the bowel downwards, but not on the artery again. You see, I freed everything from lateral. The special aspect is here, as we see soon. Well, everything is fixed here anterior. So there is a huge fixed point, and then the sigmoid goes down further. And this is because the patient had a fistula which is not that rare, a fistula in the bladder. So you have to cut it here, and you can do that also laparoscopic. It's a more difficult case. And of course, I will cut here the fistula somewhere. There's no other chance, but I don't want to harm the bladder. If I fall into the colon, it's not that bad. Then if I fall into the bladder and make a huge hole in the bladder, that would be more a problem, because the sigmoid I will resect anyway. And I try to come from both sides to free everything to just in the end cut on the anterior side. I jump a little bit forward. You see now the fistula is coming here, and I will open it. Maybe there is some stool inside and I have to put it away. You see, here's the fistula is coming. Even this is my border. So I stay in the just exact line, and this was going inside here. And I try to surround it. Of course, you have to clean it. You have to wash it. The patient is getting antibioticum for some days because he will have an infection due to the fistula anyway. So you will need antibiotics for some days. You see, this is typical part of the fistula. We try to close it a little bit, and then we just remove the last part here. And then it's complete free. And you see, this was maybe the middle part of the sigmoid. I put down the swab, and then I can lift the whole colon outside of the pelvis, and now it's possible to come to the rectum. Nevertheless, I want to cut it on the height of the promontory. Here we cut it already. In the end, we sutured this. We made a test, of course. If the fistula is open, then you suture it for 10 days. He needs a urinary catheter before you're able to remove it. And of course, you check if this is tight before you stop it. And I just show you one last video, which is important to look for the mesenteric gap, because which was 2 years before. It was a sigmoid resection for oncological reason. And you see, we looked for the small bowel, and this is the colon. And we see that there is only few bowel on the right side, and all the rest of the small bowel is on the left side, going below a very short gap. And she always had pain after the operation, not too much, but we made a CT. We did not see it clear, so we went for laparoscopy, and then we saw that there was a gap, and it's an inner hernia, and that the rest of the small bowel is there. And you see that when we put it down, we lift it up now, the colon. You see there should be the gap very close to Treitz flexure. And then we do as much bowel back again. And you will see, maybe we speed it up a little bit. Okay, perfect. You see there's nearly the whole bowel is on the left upper quadrant, and you can imagine that she always had problems. And when it went through, the problem was gone, but all 2-3 weeks she really had pain, and nobody figured out. So we went for laparoscopy. And I would really recommend, if you free Treitz flexure, in the end of the operation, it's just a few minutes. You see the gap is not very large, but that's enough that you have an inner hernia. So if possible, always close this gap in the highest part where Treitz flexure is. So the peristalsis will always go under the new meso you have here, and you have to close this. If you do that in the first operation, it's just a few minutes to do it, and then the problem is gone. Okay, we close that complete, you can imagine. So I proceed with the next thing, where you can put out the specimen. Of course, if you have a large specimen, it makes no sense to make a very large incision, and this must be adequate to the tumor size. You should not have it too small. You should always use at least the protection file. I always do it in a bag, especially if it's malignant, because I don't want to have any rupture of the colon, and also not for the mesocolon while I do the retrieval. And most common, this will be a Pfannenstiel. Many people do that. You should not resect the rectus muscle. It's not necessary. You can just do it without an incision of the rectus muscle. It's normal, that mobile. You can use the appendicectomy car or umbilical. For example, it looks like this. You have here the Pfannenstiel, you put a protection foil, you can lift it up. That's one option. Or umbilical, another option. In the end, it should look like this. Of course, you can go for scalise surgery if you not only use transumbilical, but also transvaginal is an option. And if it's a left-sided, we could discuss the transrectal. Rarely this is done, but just to show you what is possible, these are 5 people, 4 of them are operated. And if you figure out who had the hernia, who had the pancreatic resection, the cholecystectomy, or the colon, maybe you're not able to say it, and you're not even able to say who was not operated, and I will not make a guess out of that. It's like this, but everybody could look after 1 year like this. And the last thing is the anastomosis. Left side normally is double stapling. The concept is not new. You see, that's more than 100 years old, when they had some rings inside to make compression together. Even that rings and also those who went by themselves, they are gone. Now we do other things, we do double stapling, but in the end, what we know, we want to have a very nice and nearly not to see anastomosis where the blood vessels are growing through. And this is a nice picture of Friedrich Herbst, who will be with us in one of the webinars of the rectal cancer surgery later on. You need the tension-free, good blood supply, adequate hemostasis, and also lumen and tightness should be perfect. There are some other things you can do if the tension is not perfect. Make your mobilization and go in again and do that again. The ICG test is an option. You can do it open dissection, Also, you can check the hemostasis not only from extra but also intraluminal, and also if there's an adequate lumen, you should be sure that this is perfect. And you have a look for the air leak and look on the donuts. This is just for the anastomotic blood supply. You will see that, and this will be an own webinar module, because this is very important to figure out where the blood supply is perfect for your anastomosis, because if there's no blood supply, it will not be a good anastomosis. You see, this is the double stapling technique. You should be very familiar and you should know what happens with your instrument. There are a lot of courses, but this is crucial that you figure out where your purse string should be, how this works, how large is the size, how the knife works, and also how you put it in, because some are just going up and you see it's perfect curved, the instrument, but the curve is if it's inside. So if you start and you just go up, maybe you end up in the bladder or in the uterus. So you have to really consider that from the anus it's going down, where there are some folds inside until you come up. You should not rupture your rectal stump. That's also not nice if you make a damage. And then you should know there are some different diameters. We don't use 21 or 25, it's 28 upwards. There are some other numbers, but you also should know that the height is of the staples is different. That's the one thing, and also the inner diameter. So if you have, for example, a 28, that's the outer diameter, it's 25.6, but the inner is around 2 centimeters. So don't expect to have 3 centimeters if it's a 28. It's the outer diameter and not the inner. But this is important to know, that also the region in here, the package you have, your donuts will be in. This space is more narrow than the space of the 31 and the most you have on the 33, and that really depends also on the tissue you were working at. Now there are 3 stapler lines already in the newer ones, and you have to be aware that also you want to have maybe the larger ones. For example, if we do a Hartmann reversal or there is some scary tissue, it's important to have the larger staples and not the smallest. If it's jejunum, if it's ilium, you make a stapling, maybe it's better to have the smaller ones. This is a nice video from Andreas, and I found it and I thought I will show you, from Andreas Charnier, where he was looking with endoscopy, and I think they do that routinely. This is the after the anastomosis, the intra-abdominal picture, and this is the colonoscopy picture where they do it at the same time. I always say to my youngers, you can really put in some air, because peristalsis also does not take care of that. So if you damage it immediate by the colonoscopy, so then it's not a good one. And you see how it looks like, and you should be used to that. What is the picture? You see the mucosa is perfect. There is no bleeding. This you will never see if you only do the air leak test. It's very good to check inside. How does it look? Is there any leakage? If you have enough air, you will see bubbles coming out. And in this case, maybe you see it here. There are very tiny bubbles coming out. We are not sure if this is really relevant, but if you see that, and it's the typical part of the crossing of the stapler lines, the circular and the linear are meeting here, and you have some bubbles coming out, you can easily make a suture over that. You can control the suture while you do the endoscopy. So that's a very good option to do that. And I really recommend to make a perfect check of your anastomosis in the end. I know somebody of you is already tired at the end of the operation, and then the anastomosis comes, and this is the really most crucial part and very important for the patient, that you maybe make a team timeout for 20 seconds and say, okay, now the last thing is the anastomosis. Please, everybody be prepared. We refresh, and now we do for 10 minutes high concentration to do a perfect anastomosis. This is my recommendation. And then I want to check if everybody knows already, if you're interested to go on a perfect course to learn colorectal, but everything else also, maybe hernia, bariatric, and HPB, this will be in Davos, and you can register for next year soon on this web page. Thanks a lot.
Thank you, Walter, for this really excellent presentation. And we will have, I think I just wrote down a couple of questions from the audience for Colin and for you, but we are a little short of time. So we move on for the next presentation, and I will add on what you started already, and show you some tips and tricks on colorectal surgery. So I just look for the correct presentation. This one, okay. So can you see the presentation? Here we go. So it's my part to give you some tips and tricks from passing from open to laparoscopic procedure. And first, I will show you an analysis done by the government, which we have a quality control, like the NASQIP in the USA. We have it in our region, and the results of 10 clinics are systematically collected by the government, and more than 50 parameters from money, from CT scan, laboratory finding, everything, and even 45 days after discharge of the clinic, all the complications are in these results. And what I want to show you, we decided in high volume, we separated high volume and low volume clinics. The benchmark, which we said is 60 resections a year. And you can see that the blue one is open resection, and the black and white one is the laparoscopic procedure. And in the low volume clinics, that's why we ask the questions. In the low volume clinics, 80% of the resections are primarily done of elective colonic oncologic without diverticulitis and penisis, is in the year 2020 open. 80%, 30 years after the introduction of laparoscopy. And in the high volume clinics is up to 60% done by the laparoscopic approach. The conversion rate is similar from the low volume to the high volume, between 4 and 5%. And if we look, the indications in colorectal disease, in oncologic, benign and emergency surgery, you can always see the high volume clinics, they have almost 80% elective oncologic resections, whereas the low volume have only 40 and more acute. So that suggests that if you're a high volume center and you have a name in your region, that the patients now, they come from far away to your clinic for elective surgery, but in emergency situation on the county side, they cannot go so far. They go even in the non so experienced low volume clinics. So what I want to show you, coming back to how to move from open to laparoscopic surgery, the higher the caseload, the faster the learning curve will be. And you have to try to convince the general practitioner and all the gastroenterologists in your area that your clinic and you as a surgeon are the best team, the best institution for colorectal surgery, for laparoscopic colorectal surgery. And this can be done by just evenings where you invite all your colleagues, the general practitioner and gastroenterologist, for information, give some lectures, show videos. You also need to have enough availability. If the gastroenterologist calls you, I just found a sigmoid cancer, you cannot say send him in the office, in the clinic within in 3 weeks. You have just to say that, okay, tomorrow 11 in the morning he can be in our office and we will talk to your patient. So you must be a really service. You give them some service, and of course you should do in your clinic standard operating procedures that all the team and the surgeons who do colorectal know, and the nurses, 1, 2, 3, this is the first step, the second step, so that it's a really standardized procedure which helps you for the best results. And I know from about 100 courses I run in my clinic on colorectal laparoscopic surgery. We always ask our guests what happens in their clinic. And the first procedures, of course, they take more time, and you have to just respect this by doing the schedule for the operation planning. Which means that the colleagues from the small clinics always tell me there would be an ideal case on laparoscopic surgery, but they have so much to do. So the senior surgeon says, I will do it in 1 hour open. We cannot afford working 3 hours because then we cannot do the other operations. So you have to avoid this. Do a nice planning and take your time for the first procedures. And then laparoscopy is teamwork. So if you start with, if you're just only 1 or 2 surgeons, the first procedures, the first 30 to 50 procedures should be done from the same 2 surgeons. And then if 1 or 2 surgeons are experienced enough, a third one can brought in the team. And very important, bring in your nurses, take 1 or 2 scrub nurses and just let them be a fixed part of the team, that the first 50 cases, always the same people on the table. And check your blind understanding with your colleagues. If you're a good team, the first assistant who leads the camera, the optic, knows your movements and avoids clashing. And avoids clashing, meaning that you do not have to clean the lens, that it's a smooth operation, a procedure step by step. Just show you a picture. So this is left flexure. You can see garrota fascia, pancreas, and a small hole where we go in. And my first assistant, he's a consultant who performed already more than 300 cases. He knows where I go. And when I go in, he goes in. And when I go back without talking, he goes back. And we usually perform laparoscopic colorectal procedure without clashing together, without cleaning the lens of the optic. So this is here in the very narrow space, and going down to the rectum, you see it's a male pelvis. You go down, and usually you change from the left side to the right side, from the anterior wall to the posterior wall. It's very important, even when the fog comes, that he goes in and goes back without talking. There's a blind understanding that he doesn't just touch with the lens the fatty tissue. So be a team, and for the first 50 cases, always the same people. Then next, just try to go to really good clinics for courses, intensive workshops. And one which I want to recommend is the EarCut in Strasbourg. There's also one in Brazil and Korea if you want to go a little farther. And these are courses where you have the best of the best showing presentations and videos. And there's also a dry lab where you can work on the pick and on the drainer, even with the Da Vinci if you want to go there for. So this is one of the best things you have to do at the beginning. And after you perform some cases, go in for a second course, for the advanced course. Then you know where your problems are and what to do. We already mentioned the last module, one of the best courses in Davos, in Switzerland, which will be in a few months in September in Davos. So the next step is go to clinical immersions. Clinics like Walter, like Collins, many clinics offer that you go there with your team, take your scrub nurse, take your first assistants, and you be part in the OR. Usually they're only small groups, 5 patients, 5 surgeons, 4 surgeons, not more. And you go in the clinic for 1, 2, 3, 5 days and can see a couple of laparoscopic colorectal procedures. And if you want to have it real perfect, take the anesthesiologist, because usually if they're not familiar with doing the steep Trendelenburg position, if they don't know the liquid management, it will really be bad for you to have good anesthesiology. As I said, standard operating procedures, which this is one which really helps you. Just go in different clinics, take the best of the best, and then pick out for your technique the best step, first step, second step, third step, and then try to repeat on each patient these steps, make it written down, put it in the computer, discuss it with their colleagues, so that everyone who works, who do laparoscopic left, right colon, does it the same way. Now, Walter started with patient selection. Let me say one word. A small carcinoma usually is easier than a complicated diverticulitis. This should be respected because some papers say you have to do 30 benign cases before you go on cancer. The carcinoma at the rectal sigmoid, we talk only left side today, right side will be the next model. At the junction with a good indication, don't go up to the flexure, don't go up in the high descending colon, it's difficult, much more difficult, and don't go in the low rectum for the beginning. And try to choose non-previously operated patients. Very bad patients are usually after open cholecystectomy, after trauma and bleeding, and after small bowel obstruction and arteriolysis. We already have seen from Walter not choose too fatty patient, but advice for the beginning, please don't choose too slim patients. I show you why. So this is just classic, open cholecystectomy. This was a very fatty patient having operated on a gynecological carcinoma and putting out a laparoscopic sigmoid carcinoma, which is not the best indication due to the fatty tissue and the laparotomy for the first. And if patients have such a hernia, you may get, if you're not used to work in single port, and this is not for the beginners, it makes it very difficult to get the air tight there. So this is a video, classical adhesions after open cholecystectomy. Usually the transverse colon is stuck to the abdomen, to the abdominal wall by the great omentum, and this is what it looks like if you go in with the first port, and you can start doing 1 hour of arteriolysis before you start the operation which you want to, the colectomy. And unfortunately, you have to bring down all the adhesions. You cannot say, I do something and then I start with the procedure, because if I go to the next video, you have, if you want to do a good left-sided colectomy, you have bring it up, and Colin showed this, the great omentum up behind the colon. You have to see the tenia libera, otherwise you won't be able, as we heard in the first module a few days ago, to see the region of interest. You have to bring up the omentum to see here the tenia libera. Then you can remove the small bowel. And if there are some adhesions here stuck left, you won't be able to perform like this. And then, if you have a very slim patient, these are the steps you have been seen already from Colin and from Walter. Go to the ligament of Triads, searching for the inferior mesenteric vein, and then find the right plane. And this, you can see, I usually prefer to work with electrocautery, because the sealing systems seal the planes and we want to separate the anatomical planes. But if the patient is very slim, you can see a very, very narrow meso, which makes it really difficult from the beginning to stay in the right plane on garrota. So if the patient has a little more fatty, it might be more easier to do. You can see this, you have to take care of this plane of the meso of the descending colon. And in the very slim patient, it's almost more difficult than if they're a little more fatty, but of course not too fat. So good indications, just as an example, see the very long sigma. First patient, you have a very long sigmoid, and then after the sigmoid, the carcinoma should be in the at the junction. It's marked. I can show you here. It's marked, and then this is a perfect indication for the first resections. You can show this on CT scan, long sigmoid. This is perfect for the first operation. So, and finally, there is an old fairy tale that the open laparoscopic procedure has to be the same as in open. And usually left colon, you start with left colon, you start open while searching for the ureter from lateral. Forget this fairy tale, learn a complete new technique, go in there, search. This is non-cut for medial. If you go in the right plane, you find the ureter, you can see it here. You can find much more easier and much faster than from the lateral approach, and you're in the right plane as shown from Walter and Colin. Record all your operations. I have more than thousands of records of that. Here is the name, all the data, each operation. This is my explanation what's on, and if there's some interesting, I have a computer system to find all these videos. So that's just from my point so far today. Thank you for listening, and we move now on for the next presentation to Khaled, Professor Mabdouli, and he will show us his local experience in Egypt.
Hello, good afternoon. I talk about anything technical in this session. We're going to talk about some local perspective and regional specifics here in Egypt. So this is the overview. This is what we're going to talk about. We're going to talk the percentage of different indications of left colectomy. Indications are pretty much the same everywhere. However, the percentage of indications may be different here. And the percentage of laparoscopic left colectomy here in Egypt, and why laparoscopic left colectomy is different in the Middle East in general, and some health conditions that are common and make it complicated, and why we have longer lengths of stay for many reasons, and some quick note about the cost issues, as most healthcare finance are here out of pocket. So the main indications, about 87% of left colon resections are due to, and sigmoid resection are due to malignancy. 9% is due to sigmoid diverticular disease, and 4% of all other indications, benign sessile strictures, Crohn's strictures, ischemic colitis, bleeding and actinomycosis, or any others. So majority are malignancy. Laparoscopic left colectomy started here in Egypt and Alexandria in 1999. However, it took around a decade until 2010 till it becomes the standard of care. Number of trained colorectal surgeons in the whole Egypt around 52, and number of trained laparoscopic colorectal surgeons are 18. Actually, we have trained many more. However, many are working outside the country in the Gulf area, in Europe, and in USA. The numbers of left colectomies done by colorectal surgeons, only 18 to 20%, and 80% are done by general surgeons who are doing colorectal procedures. Number of left colectomies per year, estimation around 3,000, 3,500. Don't have a strict registry here in Egypt, so it's an estimated number. However, the percentage of laparoscopic left colectomy only from 13 to 15%, and all are done in the big centers. And so we tried to do some standardization of the laparoscopic resection procedure in Egypt. Has been done in the National Institute and published probably a decade ago in order to overcome the challenges. What are the challenges that we might face? First, young age. We have the mean age around 42, so we are dealing about young age of malignancies. No screening process, so we are dealing usually with the advanced stage and with the big tumors. Hepatitis and portal hypertension make it technically difficult because there is a lot of bleeding and a lot of portosystemic collaterals, and bleeding is pretty common in these procedures. The costs we're going to talk about in a few seconds, longer lengths of stay, and obesity. So the high percentage of large and locally advanced tumor because of the absence of the screening program. We are talking about only 8% of our cases are between stage 1 and 2. However, most of the cases are between stage 3 and 4. And more than 30% of our presentation are due to obstruction, partial or complete, versus only 20% worldwide. And the specimen retrieval from left iliac incision is not easy because usually the tumors are big. And so sometimes you need a really big incision or to do a fenestile incision, as Andreas talked about a few seconds ago. Obesity, the WHO announced in 2010 that Egypt has the highest percentage of obesity in the Middle East or in Africa, and 14%, and in the 14th position all over the world. In 2012, around 62% of adults in Egypt are overweight, and 31% have morbid obesity. So the learning curve is more difficult here among our staff, simply because the obesity is making it more difficult in these situations. The portal hypertension, a large number of patients have portal hypertension either due to old hepatitis C or sometimes due to schistosomiasis. Portosystemic collaterals and the higher possibility of bleeding add more difficulty to the laparoscopic surgery. And many had child B liver function, no child A with low albumin level, which might affect the anastomotic healing later on. Length of stay, the fast track protocol is not widely adopted among non-colorectal surgeons. Definitely it's adopted between colorectal surgeons, but non-colorectal surgeons are not adopting it that much. Anesthesiologists, not much oriented about the restricted and the goal-directed fluid therapy, so sometimes we have salt and water retention and overload of fluid. So these have implication on the post-operative areas. And the socioeconomic status, difficult to rapid discharge of patients from hospital. The cost, the direct hospital cost of laparoscopic left colectomy here around $200,000 extra than the open procedures among non-colorectal surgeons. And the insurance company's reimbursement is still the same as open procedure. And the major determinants of the cost depend on the longer operative time, disposable instruments, port, energy devices, such as the ligature and the stapling devices. However, if you go to a specialized center, the picture is totally different. Operative time reduced with the increasing experience. Cost saving from laparoscopy is determined by the length of stay, which is consistently between 2 to 3 days shorter in our published series compared to open surgery. And the cost saving also from reusable Trokar and reusable instruments, and the total direct cost in a specialized center around $500 less in laparoscopic left colectomy compared to open. This is what I'm going to talk about, and thank you.
Thank you. Thank you very much for this precise and concise presentation. So maybe we see all the lectures, all the presenters again, and we have a couple of questions and we have a couple of time now, and I would just have a few questions which we received, which I can answer straight now. There was one question, which company is the ligature, and it's the company of the organizer of this meeting, which I want to thank you. It's of Medtronic. So the ligature in the videos is from Medtronic. And there's another question: is there a ligature with an electric hook available? And yes, it's called ligature hook, and it's especially good for rectal cancer because you can have the bipolar ligature, and you also have, by moving out the hook, the electrocautery at the tip of it. And there was also another one with not a hook, with a small blade outside, but there is one with a hook. So I will start with one question to Maite and the organizations. There are some questions asking if these modules will be available on a YouTube channel, if they will be available for download. So Maite, maybe you can answer these questions from the company side.
Yes, we are recording the modules and will be available in the near future. So we will post the people once it's available. Thank you.
Okay. So Walter, there was one question for you. What are you using for the bowel preparation? What is your experience and your just very short, which medicine, which substance for mechanical bowel preparation do you recommend?
So actually, as I told you, we only do it in rectal cancer patients where we do diverting stoma, and we use the same as for colonoscopy. So they should really be clean, and only in obstipated patients we take some medication because we don't want to have obstipation for all the other colon resections, which is rarely the case. But if people are very obstipated, the day before they take some medication, maybe they drink 1 liter also of the same, and this depends on the country you are living in. You can take the same as for colonoscopy, which is usually in your hospital or in your region.
Okay, thank you. Maite, we have another few minutes. I know we run out of time. Possible to have another 5 minutes for the questions?
Yes, no problem.
Okay. So Colin, one question for you. How do you deal on the left flexure, left column if you have a very shrunken, short mesentery?
You have to mobilize even more. I think that's the main part. You always have to mobilize as much as possible, and if your mesentery is shrunken, then you have to free as far as possible. Sometimes it's just too short to re-anastomose, but you have to room between the middle colic artery and the sigmoid artery, and sometimes you have to cut one of the two to have enough length. But preferably, I keep them. But then that's I think that's where the length is caught.
Okay. Another question is carcinoma on the left flexure. You said in that case you leave the mid-colic artery. So from the lymph nodes, when do you take out the mid-colic artery and when can you just save it?
It depends on the exact location. I think nobody knows that exactly. If it's more to the flexure, I'll keep it. I'll keep the middle colic artery. But if it's if the tumor is more to the transverse colon than to the flexure, then you have to cut it. And then personally, I prefer to do an extended right hemicolectomy. I know Walter does a transverse resection sometimes. But it's not an exact science. I mean, it all depends where you see it in relation to your vascularization.
Okay. So there's one question about the courses we presented last module. Are the courses available not only on the box? And the answer is yes. Walter Brunner showed the course in St. Gallen where you have lots of training on tissue. There are courses with cadaver workshops, and there are also courses where you're live in the OR and be part of the procedure. So just check out the internet, check the clinics. There are lots of courses with different types, in-housing for 1, 2, or 3 days. So one question for Walter said, when do you do the anal specimen retrieval?
So that's very rare that this is done, but only if you have included your opening of the rectal stump in the anastomosis. So there are only some specialists. We did some series of that, but this is not standard. Where we do it is if we do transanal T&E, then you have the rectal stump open and you can do it, but only if you don't harm the sphincter.
Okay, thank you. So we have 1 minute, one question. If in extended left hemicolectomy, if the remnant column does not reach the distal segment, even after extra mobilization, what option do you have to solve this issue? Khaled, what is your opinion? One answer from each.
I didn't hear the question. Can you repeat it again? Sorry.
If the left column it does not reach after extended mobilization down to the anastomosis, what can you do?
I mobilize the transverse colon. Sometimes I take, I completely separate the omentum. Sometimes I mobilize the hepatic flexure. If not, if everything of these didn't work, sometimes I do the lower procedure. I just rotate it to the other side and do the anastomosis. It depends according to the case.
Okay. Colin, what is your option?
Yeah, well, the same is mobilize as far as possible, and then sometimes you have to lead it down on the right side, or even make an opening in the mesentery of the small bowel to get it across. But that's 1 in every 10 years.
Yeah,
that doesn't happen that often.
Walter is saying yes by his head.
I totally agree. Those two options, if you have mobilized until mid-colic artery and that's it, you can turn it on the right side. You cut the mid-colic central and make a deloat, or you put it via the mesoileum. Mesoileum, you make a window and you put it down there if you think this is enough length.
So this is what we do in such situation, the Flühe operation. Yes. Okay. So I think this has been now the answer of the most questions. There are questions on tips and tricks to control bleeding. There will be a webinar on that. Tips on identifying the mid-colic artery. I think we have seen this in the video. Do you think that do you use ICG routinely? There will be also a topic on that. So just please follow us for the next 9 modules and all these questions will be answered. So I think we come to an end. You will all get a questionnaire later on. I hope you enjoyed this webinar, this second one. I want to say thank you to the complete faculty, to Khaled, best greetings to Egypt, Walter to Switzerland or the border in Austria, and Colin to the Netherlands. Thank you for the complete team, which should be named Hilton Strauss, Maite Sens, Baher El Badri, and Hugo Kuna. Thank you, all of you, for organizing in the background all the meetings, and we're looking forward for the next module. Thank you for your attention.